it's 12 noon, so we'll get started. Good afternoon, everyone. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please answer a brief survey that will be sent to you immediately after the presentation. This will let us know that you were present today, and please enter your questions in the chat and we'll get to them at the end of the presentation. And finally, our speaker today is coming to us courtesy of the Division of Rheumatology. I would like to ask the Chief of Rheumatology, Dr. Beth Hazel, to please present our speaker today. Thank you.
So I'm actually just the site director at MUHC, but Marie Hudson is on the call. She is our rheumatology division chief. But I am super excited to introduce the MUHC community to our newest member. Dr. Nader Toban did his training at Université de Montreal and a master's in experimental medicine. And he was recruited to replace the Lachine rheumatologist that had served there for many, many years. And so he's providing community service to rheumatology in our Lachine community. And he's also working at the GCSM where he's having his niche interest in immune-related adverse events of cancer. And he's been seeing a lot of the patients at the Vic with these events. And in the future, he's going to do more work. Dr. Hudson's team is very strong in learning about this domain in rheumatology, and he's going to be helping to recruit patients for studies and work with that group. So if you see him in the hallways when he's on call or at the GCSM, then please say hello, and looking forward to hearing about this talk. Take care.
Thank you, Dr. Hazel, and thank you to the Department of Medicine for allowing me to speak today about this topic, which is very important to me and very interesting to the wider McGill community, I believe. Now, at the end of this presentation, participants should be able to describe immune-related checkpoint inhibitor mechanisms of actions and the pathophysiology of the adverse events that often plague patients on these life-saving therapies. The focus of the talk will be in the recognition of the presentation of major rheumatic irAEs and in the management of rheumatic adverse events. Now, what I'd like to also focus on briefly is in evaluating the risk of immune-related adverse events in patients with pre-existing autoimmune diseases. I have no conflict of interest to disclose and no relevant financial conflicts of interest related to this presentation. Now, in order to understand how immune checkpoint inhibitors work and how they lead to toxicity, it's good to evaluate, to explain the role of immune checkpoints in the immune system. Now, T cell activation is generally a two-step process. The binding of an antigen-presenting cell to a T cell via the T cell receptor and the presentation of an antigen is not sufficient for T cell activation. It requires a co-stimulatory signal in the form of CD80 and CD86 CD80 or CD86 expression on the surface of the antigen-presenting cell, here in the diagram, a dendritic cell, and it's binding to CD28. The combination of these signals leads to the activation of the T cell, and the magnitude of the T cell response will also swing the pendulum backwards, in that a process begins by which CTLA-4 is trafficked to the surface of T cells, and this serves as a higher affinity binding, serves to bind rather CD80 and CD86 with higher affinity than CD28, and leads to a balancing inhibitory signal. This is thought to prevent aberrant T cell activation, off-target effects, and autoimmunity. And This is one of the checkpoints. The other checkpoint is more of a tissue, is more found in tissue, and it's the expression of PDL1 on the surface on surface of tissue cells, and it's binding to PD1, which serves as another inhibitory signal, preventing off-target effects on normal tissues. Now, so the T cell response is tightly regulated, and this is thought to have a protective effect. Where this gets interesting is that in cancer cells, there are ways to evade the immune system by exploiting these checkpoints. Some tumor cells will express PDL1 at a higher level than baseline, or will constitutively express it, and this will lead to an inhibitory response and prevent T cell activation and effects on tumor cells. There's also an adaptive immune resistance which develops by which an inflammatory signal leads to the upregulation of PDL1, binding with PD1 on T cells, and a subsequent inhibitory signal. To exploit this, cancer immunotherapy has been developed over the last few decades. Interestingly, among the first uses of immunotherapy was via recombinant IL-2, an immune cytokine, and this was used for renal cell carcinoma in a few cases. This is back in the 90s. Later on, in the late 90s and early 2000s, there was development of molecules that inhibit CTLA-4, ipilimumab being the first one, and it was used in clinical trials and then in clinical use subsequently. Afterwards, there was a development of PD-L1 and PD-1 axis inhibitors. And this has really expanded over the last few decades. Why this is interesting to rheumatologists in particular is that we use these checkpoints in a different way. CTLA-4 agonists are used in the treatment of RA and other autoimmune rheumatic diseases. And so we tend to exploit the opposite effect to blunt T cell responses and provide a anti-inflammatory and rather immunosuppressive effect. So immune checkpoint inhibitors work mainly by either binding and inhibiting CTLA-4 on native T cells, naive rather T cells. And this is something that occurs in lymphoid organs. This prevents the inhibitory signal, the higher affinity CTLA-4 from binding to B7 and inhibiting the T cell response, and allows for greater binding of CD28 to B7 and primes the T cells in the lymphoid organs to then go out and seek cancer cells. Of course, this is non-specific, and as you'll see later, there are multiple off-target effects related to this. In target tissues, a different approach is adopted, and here PD-1 or PD-L1 inhibitors prevent the inhibitory signal from preventing T cells from actively targeting cancer cells, especially those that express high levels of PD-1 on their PD-L1 rather on their surfaces. And for illustrative purposes, here are a list of different immune checkpoint inhibitors and their mechanism of action. So this is just immune checkpoint inhibitors are just one type of cancer immunotherapy. And over the years, it's really reached mainstream use. Over 50% of cancer patients were eligible for immune checkpoint inhibitors based on a study in 2023 in American patients. The main use is in non-small cell lung cancer, melanoma, renal cancer, and other solid malignancies. Over the years, we're seeing increasing first-line use in adjuvant and neoadjuvant settings, and there are currently 13 FDA-approved drugs with various targets. Now, regarding immune-related adverse events, the target of aberrant T cell activation is rather wide, and pretty much any organ system can be affected by immune-related adverse events. Now, there are some differences in what is seen more often with PD-1 versus CTLA-4 blockade, and what is seen with CTLA-4 and PD-1 combination blockade. Fortunately, what tends to happen is that the more common side effects are the milder ones, and the deadly and more severe side effects or adverse events are the ones who are rarer. There's increasing recognition, and this is interesting if you look at the figure here from a review in 2021. Arthralgia is mentioned, but nothing is said about arthritis. And over the years, increasing recognition of immune checkpoint inhibitor-related arthritis and other musculoskeletal complications are being discovered. And then, if we had to place it somewhere on this scale, it would be somewhere below colitis, maybe above pneumonitis. So it's rather common and tends to be moderately severe. So many mechanisms can be associated with the development of immune-related adverse events. Just like with autoimmunity and like autoimmunity in general, the presence of an immune response can spread out at the target tissue and cause cellular damage and the presentation of other antigens, which leads to a phenomenon of epitope spreading, whereby due to the damage and the magnitude of the inflammatory response at the tissue, other antigens, normal or rather tissue antigens, are recognized as foreign or infectious and are then targeted by the immune system. Epitope sharing can occur whereby antigens with similar sequences can be recognized by antibodies produced to fight the cancer. Direct toxicity can exist as well, and this is thought to have a role in hypophysitis, where the immune checkpoint inhibitors can have direct off-target effects on normal tissues. And as we're recognizing increasingly, flares of pre-existing autoimmune diseases are another mechanism of toxicity. Often these are diseases that are either not recognized because they're subclinical, and later on in studies using serum of patients, we see that a certain subset of, let's say, for example, seropositive rheumatoid arthritis caused by immune checkpoint inhibitors occurs in patients with rheumatoid factor or anti-CCP positivity before the use of the immune checkpoints. I'll briefly go over the immune-related adverse events affecting other systems before focusing more on the musculoskeletal and rheumatic adverse events. Among the most common are dermatologic adverse events. So what is generally seen is a rash, which could be maculopapular, edematous, and the range of events or complications is rather wide. You can have pruritus, vitiligo, and it tends to occur, especially the milder rashes, in up to 70% of patients. There's a lot of heterogeneity in the reporting of adverse events, which explains why a lot of these percentages are quite wide. But all this to say that this is a rather common system to be affected by immunotherapy. And it's, of course, like many adverse events, greater with combination therapy. Rarely, patients will get severe skin adverse events like Stevens-Johnson syndrome, TEN, DRESS, or blistering lesions. When it comes to gastrointestinal side effects, diarrhea and colitis are rather common, especially diarrhea, and can occur with CTLA-4 agents. This tends to be an early adverse event within the second or third dose, so within the first few months of immunotherapy, and it's in some studies tends to be more common with melanoma. In combination immunotherapy, so immunotherapy that targets both PD-1, PD-L1 axis and CTLA-4, diarrhea could be found in up to 50% of patients of all grades, and up to 20% can be severe and warrant the interruption or discontinuation of immunotherapy, in hospital treatment, IV steroids, and other immunosuppressants. When it comes to hepatotoxicity, it can range from asymptomatic transaminitis to liver dysfunction and can progress rapidly, so it's always good to keep an eye on that. Endocrine dysfunction is also common. What tends to occur often is thyroid dysfunction, so thyroiditis and subsequent hypothyroidism. The PGA axis can also be affected, and hypophysitis is thought to occur in about 1 to 5%, more with combination therapy. Primary adrenal insufficiency is rather rare. Type 1 diabetes can also occur, but fortunately this is quite uncommon, and it can present as diabetic ketoacidosis in patients treated with PD-1 more often than CTLA-4 inhibitors. Pulmonary toxicity tends to occur in about 10% and can range from asymptomatic to respiratory failure. Pneumonitis, sarcoidosis, effusions, and airway disease can occur. In imaging, the findings are rather nonspecific, and can depend on the type of lung disease. Neurotoxicity is of special interest in the case in its association with myositis. Fortunately, what tends to be found is mild peripheral neuropathy, but rarely severe syndromes like Guillain-Barré, transverse myelitis, and myasthenia gravis can occur. And myasthenia gravis and other neuromuscular disease is associated with myositis and portends a more lethal disease. Myocarditis is also rare, tends to occur with combination therapy, and starts rather early after ICI initiation. Mortality is high, up to 50%, can be even higher if associated with myositis and myasthenia gravis, and often occurs with other immune-related adverse events. In order to understand and treat immune-related adverse events, grading is essential, and most adverse events tend to range between grade 1 and 3. Grade 4 is rather rare, and 5 is fortunately uncommon. The distinction between grade 2 and grade 3 is important because that's where we tend to interrupt immunotherapy, and the main distinction is in the severity of the limitation in ADLs, and the possibility of hospitalization or an in-hospital treatment. When it comes to rheumatic immune-related adverse events, almost every rheumatic disease can have an immune-related adverse events equivalent. Now, fortunately, the more severe ones tend to be rather rare, but what is often seen in patients is inflammatory arthritis, PMR-like presentation, Sicca syndrome, rarely myositis, sarcoidosis, psoriasis, psoriatic arthritis, and vasculitis. Scleroderma is increasingly being recognized, and there are forms of vascular disease like severe Raynaud's with critical ischemia that have been described. Now, when I say that they have equivalents, what's important to note is that they're not exactly the same. They're treated differently and may present in interesting and different ways. And in terms of prognosis, there are some differences that will be highlighted later. So to change gears a little bit, I'd like to talk about a case of typical presentation, something that I see rather often with patients on immune checkpoint inhibitors. So this is a 80-year-old woman with gastric cancer who is given neoadjuvant combination immunotherapy, so ipilimumab and nivolumab, before subtotal gastrectomy. Interestingly, this is a patient with significant multi-level osteoarthritis, which rendered the evaluation of joint pain rather difficult. She developed a PMR-like presentation within a few months of having started immunotherapy, and this was this presented with scapular and pelvic girdle pain, stiffness, and mainly morning stiffness lasting more than an hour, even several hours at first. There was significant impact on her activities of daily living, and she was requiring more and more help from her family. Initially, she didn't have any clear joint involvement, and what I mean by that is there was no synovitis on examination. And this patient was seronegative for rheumatoid factor, anti-CCP, and ANA. What I suspected here was immunotherapy-related PMR, and started her on prednisone with a taper down to 10 milligrams, which was well tolerated and led to an improvement in symptoms. Immunotherapy was stopped more due to the fact that she had completed her neoadjuvant treatment and was recovering from surgery. And once she was at 5 milligrams, I happened to be on call that time. She presented to the ER with severe grade 3, so ADL limiting polyarthritis with bilateral MCP, PIP, wrist, and knee involvement. And at the same time, worsening PMR symptoms. At the ER, I gave her IM Depomedrol, so intramuscular steroids, and started her on methotrexate. Prednisone was slowly tapered afterwards. She improved within for the first few months, and then flared again with when prednisone was discontinued. With this time more PMR symptoms than arthritis, and this is something I'll highlight later in the differences between PMR that we see in patients without immunotherapy and the PMR that develops on immunotherapy. Her arthritis seemed to be well controlled on the DMARD, but it seems like the PMR was responsible for most of her symptoms at that point. Quickly, I'd just like to touch on the difference difference between inflammatory and mechanical arthralgia. The clinical distinction is important in improving the quality of referrals and also in recognizing immune-related adverse events. Generally, inflammatory arthralgia will present with significant morning stiffness lasting 30 to 60 minutes or more, often more. Nighttime pain is often found, and it's associated with waking up sometime in the early morning after 12. Patients who report waking up because they're in so much pain 2-3 hours before they usually wake up. In this case, it could be due to inflammatory arthralgia. Generally, it tends to improve with activity and worsen with rest and immobilization, like at night. And on exam, this will be associated with swollen, tender, and possibly warm joints, although this is not always the case. On examination, they'll have reduced range of motion and stress pain in the affected joints. And this leads to us talking about immune-related inflammatory arthritis, which should be distinguished from arthralgia, so the presence of inflammatory joint pain without measurable or objective synovitis on exam. Inflammatory arthritis tends to occur in 1 to 7% of patients. The real number is probably closer to 4. Combination PD-1 and CTLA-4 tends to cause it to occur more often than monotherapy. Median time to onset is 4 months, and this is why it could be sometimes under-recognized in that it starts later than other immune-related adverse events affecting other organ systems. Presentation varies. So patients will most often present with symmetric polyarthritis, rheumatoid arthritis-like presentation affecting the small joints and the large joints. This is more common with PD-1 or PD-L1 inhibition. Large joint oligoarthritis or monoarthritis is less common and tends to occur with combination immunotherapy or CTLA-4 monotherapy. PMR-like presentation, which will be expanded on later, is also possible and can coexist with inflammatory arthritis. Tenosynovitis tends to be a prominent feature of these of this arthritis. Majority of patients are seronegative for typical autoantibodies found in rheumatoid arthritis and in other inflammatory arthropathies. So the majority are seronegative for rheumatoid factor and anti-CCP. Although in some studies, between 9 to 10, sometimes up to 20% can have positive autoantibodies. It's difficult to tell if these are patients who had them before or if a certain proportion of them had positive autoantibodies before. It tends to be a non-erosive disease. This might be because we don't have as much follow-up and not as many years of follow-up with these patients, and they tend to be treated quickly. But untreated ICI-related arthritis can be erosive. In the Canadian cohort, there was a good description of the among the rheumatic immune-related adverse events, the different percentages of polyarthritis, psoriatic arthritis, oligoarthritis, and PMR. Myositis and sicca tend to be rather rare. And this is from a poster at the American College of Rheumatology conference last year. It shows the detection of ultrasound detection of synovitis. Generally, the knees are more affected, and afterwards, the other small joints often affected in RA are often inflamed in immunotherapy-related arthritis. Now, there are some predictors of severity that have been discovered in retrospective studies. More severe disease tends to occur if there is presence of tenosynovitis, longer symptom duration, as with idiopathic arthritis as well. PD-1 and CTLA-4 combination tends to cause more severe disease that will likely need a DMARD or a disease-modifying anti-rheumatic drug, something like methotrexate. Inflammatory arthritis tends to persist for months to years after immunotherapy cessation, and this is something that has been more and more evident in longitudinal studies. In some, up to 87% persist after the cessation of immunotherapy. Factors associated with persistence or chronic immunotherapy-related arthritis include favorable tumor response, combination immunotherapy, swollen joints, more swollen joints, and a polyarticular presentation, and of course the presence of other immune-related adverse events. And this graph here shows that progression-free survival, so survival of patients and the lack of progression of their cancer tends to occur more often in patients with chronic inflammatory arthritis after immunotherapy. Immune-related polymyalgia rheumatica is interesting to mention here because it's rather common among musculoskeletal immune-related adverse events and can exist on a spectrum with features of peripheral arthritis, so both can exist in the same patient, and can be more severe in its presentation versus primary PMR. Like with PMR not related to immunotherapy, CRP is frequently elevated, but this isn't always a reliable indicator in cancer patients, especially those with baseline elevated CRP due to the underlying cancer or other adverse events or the immunotherapy itself. What's interesting is that there are some differences in how often this is associated with giant cell arteritis, whereas it's it's common for it to be seen with GCA in patients without immunotherapy. PMR related to immunotherapy is very infrequently associated with GCA. And patients tend to have a higher baseline requirement for corticosteroids. Something we don't often see in PMR is that up to more than a third of patients require more than 20 milligrams of prednisone daily, whereas with PMR, we can get by with an initial treatment of something like 20 milligrams or 17.5. Patients tend to require higher baseline steroids and are more steroid dependent when PMR is caused by immunotherapy. When it comes to treating immunotherapy-related inflammatory arthritis, some general principles have to be mentioned. So with mild disease, treatment is generally supportive. NSAIDs can be used, and the use of IA steroids can help avoid using systemic therapy. And the reason for that, the rationale behind that will be clearer afterwards. Moderate grade 2 disease, which affects ADL without causing the inability to self-care, can be managed with small doses of steroids between 10 to 20 milligrams. What's important is that these steroid doses be tapered afterwards. Severe grade 3 and above requires higher dose steroids, something like 0.5 to 1 milligram per kilogram initially. Other immunosuppression is increasingly being used and earlier for reasons that will be clearer in the next section. Methotrexate, hydroxychloroquine, TNF inhibitors, and IL-6 inhibitors have been used in case reports and in series. Now, sulfasalazine is highlighted, or rather in parentheses here, because of there's an increasing risk of sulfasalazine-related hypersensitivity in patients who have immunotherapy because they are primed for a T-cell response, and the severe hypersensitivity that we see rarely in patients treated with sulfasalazine might be more common in those who get immunotherapy. Treatment, of course, depends on the type of immune-related adverse event, whether it be inflammatory arthritis, arthralgia, or PMR. And what we would like to recommend is referral to outpatient rheumatology for anything grade 2 or above. Now, the reason why we're trying to move away from the use of corticosteroids, despite the fact that they're effective and fast-acting first-line agents that quickly bring the complication under control and allow for patients to resume normal daily activities and to have a better quality of life quicker, is that the patients that are treated with immunotherapy and develop inflammatory arthritis can often be steroid dependent, and as you've seen before, can develop persistent or chronic forms of inflammatory arthritis. What has been shown is that patients tend to do worse regarding their cancer if they've been exposed to higher baseline doses of prednisone. So this is regarding people who were on prednisone once immunotherapy was started. The cutoff tends to be 10 milligrams or higher per day versus less than 10 milligrams. The early versus late initiation of steroids has been associated with shorter progression-free survival from their cancer, and the cutoff seems to be about 2 months. In a retrospective study, the graph here is from that. The patients with early steroid use and the cessation of immunotherapy tended to fare the worst regarding their cancer. And so if possible, when the complication is not life-threatening or severe, we recommend, what is recommended is to limit steroid exposure, especially early on. Higher peak doses of steroids have been associated with worse outcomes. And there's some conflicting data on the cumulative dose of steroids. When it comes to treating with conventional DMARD, so what we mean by that is immunosuppressant medication like methotrexate, sulfasalazine, hydroxychloroquine, and other non-biologic molecules. Immunosuppression at baseline in patients who were already on immunosuppressants tends to be associated with worse progression-free survival. However, when it comes to treating immune-related adverse events, there is a clear benefit in using DMARDs and limiting corticosteroids with regards to lengthening progression-free survival. There's little data on the comparative efficacy or effectiveness of DMARDs. And like I mentioned before, sulfasalazine should be avoided if possible, although it tends to work a little faster than other DMARDs. Something like hydroxychloroquine, which is not considered to be an immunosuppressant, has a slower onset of action, might be appropriate for milder cases of immunotherapy-related arthritis. And the slow onset of action does tend to limit the use of this drug, mainly because while we're waiting for it to, for the effect to ramp up, then patients might be exposed to higher doses and longer duration of corticosteroids. Methotrexate tends to be a good middle ground. It has a favorable safety profile and efficacy. At doses more often given for oncology, it tends to impair T cell activation via the folate, via depletion of folates. However, what we tend to see with low-dose methotrexate treatment for rheumatic diseases is more of an anti-inflammatory effect mediated by adenosine. Very little head-to-head data exists. However, there is some observational data that compares corticosteroids alone versus corticosteroids with immunosuppressants for the treatment of immune-related adverse events. The slide, or the graph here rather, is from a study done on immunotherapy-related adverse events in general, although there was a rich proportion of rheumatic immune-related adverse events in this cohort. Patients who were treated with corticosteroids alone tended to do worse with regards to progression-free survival. Those who were not treated, and those who were treated with corticosteroids with an immunosuppressant tended to have similar outcomes. Now, it's not clear why this is, and there was a lower mean highest dose of corticosteroids in the group treated with immunosuppressants. However, the interesting difference is that those who were treated with immunosuppressants were on immunotherapy for longer, and I think the difference was something like 40 months versus 17 months.
This is not a randomized trial.
No. Randomized trials are rather.
Can't make anything up.
Yeah.
Because you choose the drug depending on the patient. It's relatively.
Right. Yeah. Well, yes. So no, of course, it's a very relevant point. Their data is lacking, and we do need head-to-head studies and prospective trials to know how to treat these patients better. Now, with regards to biologics, what was really more in the case, described in case reports and series, is getting a little bit. The data is getting a little bit better. We do have some head-to-head, or rather retrospective, but comparative studies between TNF inhibitor, IL-6 receptor inhibitors, and methotrexate. In this interesting retrospective study here, what was evident is that the TNF inhibitors led to a faster onset of arthritis control. However, the the methotrexate was associated with shorter progression-free survival versus the biologics. Long-term data, of course, is pending, and prospective data is lacking. Now, we'll change gears and just mention ICI-induced Zika syndrome. So this tends to occur in about 3 to 24%, likely less than 5% for actual Zika syndrome. And this is due to the fact that many confounders exist. Chemotherapy-induced dry eyes and dry mouth, opioids, head and neck radiation can all lead to oral and ocular dryness. With regards to Zika syndrome, mean onset tends to be within the first 2 months, and oral involvement is more often seen than ocular involvement, and this might be due to the fact that conventionally we believe that ocular or the eye is an immune privileged organ. With regards to autoantibodies, which are rather prevalent in Sjogren's syndrome, SSA and SSB tend to be negative. And what's interesting is that when salivary gland biopsies are done, we see that immunohistochemistry tends to differ versus Sjogren's, whereas the B cell infiltration is rather elevated in Sjogren's. This tends to rarely be seen in immunotherapy-related Zika syndrome, and T cells, CD8 positive T cells are found in greater proportion in immunotherapy-related Zika. Now, management tends to be somewhat similar compared to primary Sjogren's, or rather to Sjogren's. Grade 1 and 2 adverse events is treated with oral care, hydration, artificial saliva, tears, and pilocarpine, which stimulates the production of saliva. Grade 3 and above, there's a consideration for oral corticosteroids, something short, like 2 to 4 weeks. And this requires, of course, co-management with the treating oncologist, and same thing for interruption of immunotherapy itself. The Zika syndrome tends to have a large impact on quality of life, and so their patients will often complain about this, and it'll be a big issue for them. For milder cases and even some grade 3 Zika, it would be safe to continue immunotherapy. As with Sjogren's syndrome, there could be systemic manifestations due to the Zika syndrome, but this tends to be a little bit less frequent than with Sjogren's. So things like interstitial nephritis, peripheral neuropathy, they tend to occur less in ICI-induced Zika syndrome. So the second case I have here is of a 75-year-old male with metastatic melanoma. This is a recent case, patient who had recently been on dual immunotherapy with a CTLA-4 and PD-1 axis inhibitor. The patient had developed around C2, around the second cycle, arthralgias and joint stiffness. That didn't bother him very much. And then suddenly, a little later, severe joint pain, oligoarticular swelling, and this impacted his ADLs and caused him to be bedbound, to eat less, to lose weight, and he presented to the ER. He had severe, large, more than small joint polyarthritis with effusion in the shoulders, wrists, and elbows. And then what caught our attention is that his family mentioned that he had developed a new dysphonia, and that he sounded like his voice was weaker, his words were less clear, and so this was of concern to them. Initially, his CKs were normal and then became a little bit more elevated. So we're not sure if this might be due to the fact that he was bedbound or if something else was going on. His CRP was significantly elevated, and he was a patient with normal or just barely elevated CRP at baseline. He had some proximal weakness on exam, but the examination was different. He was in severe pain, and a reliable assessment of his strength was not fully possible. He didn't have dysphagia, and cardiac biomarkers were normal. He rapidly improved with prednisone. He was given rather high doses, and you'll understand a little more why in a bit. EMG didn't show any neuromuscular disease, a neuromuscular junction disease, but there might have been some discrete deltoid myopathy. The patient was discharged on high-dose prednisone and seen not too long ago as an outpatient. He had complete resolution of his arthritis, no weakness, the dysphonia resolved, and his CK was normal, and he's doing better on a prednisone taper while his immunotherapy was suspended for now. This leads to a quick mention of ICI-induced myositis, which is a rare but severe complication that can lead to high mortality, especially in association with myocarditis. This tends to occur earlier than other musculoskeletal manifestations of, or rather adverse events of immunotherapy, and can present with myalgia, weakness in the axial muscles, the girdle, the scapular and pelvic girdle, and tends to involve the oculomotor muscles, and so have this bulbar presentation. Diaphragmatic weakness is also found and can lead to and can be associated with high mortality. CK is usually elevated but can be normal as well. Aldolase can be helpful in those cases. Troponin should always be checked to make sure that the patients don't have overlapping myocarditis. Myositis associated or specific antibodies are usually negative. So our myositis panel will be sent, but it'll rarely yield positive results. These patients require inpatient evaluation by neuro and rheumatology. They should, if ICI-induced myositis is expected, they should get EMG, they should get muscle MRI and or biopsy if appropriate. The diaphragmatic weakness should be evaluated, and they should get an evaluation for dysphagia as well. If confirmed, these patients with myositis tend to get more aggressive treatment with IV steroids, IVIG, plasma exchange, and there have been cases of treatment with abatacept and other immunosuppressants. So I'd like to just mention, before concluding, patients with pre-existing autoimmune diseases and how they fare on immunotherapy. These patients have often been excluded from clinical trials because of because of an assumption of higher risk of flare and adverse events. But immunotherapy is especially relevant to them because patients with chronic inflammatory diseases and immunosuppression have a higher risk of cancer development versus non-autoimmune patients. Data from retrospective and observational studies has been piling up, and what we see is that they are at higher risk of flares. And for example, here in cohorts with rheumatoid arthritis, PMR, and psoriatic arthritis, half, if not most, will have flare-ups of their diseases, but these tend to be rather mild. Patients with baseline immunosuppression have shorter progression-free survival versus patients not on immunosuppression. In order to illustrate how these patients fare, in a recent study on patients with rheumatoid arthritis, flares were common and most often tended to occur within the first 3 months. 90% were grade 1 or 2, so were mild and manageable, and about 20% led to the disruption of immunotherapy, whether an interruption or discontinuation. So what the take-home message from this is that our patients should, when appropriate, be considered for immunotherapy. And of course, this is a matter of shared decision-making between treating rheumatologists and the oncologist. But these patients can be managed despite their higher than baseline risk of flares and also higher than baseline risk of other immunotherapy-related adverse events. When these patients get adverse events, they tend to be rather either flare-up of their underlying disease. They don't tend to have more severe immunotherapy-related adverse events. There is some conflicting data on whether they might have even lower risk of other organ immune-related adverse events. The reasoning behind that is their immune system might be primed to produce an inflammatory arthritis response, for example, in patients who have RA. There may be also a protective effect of baseline immunosuppression on the development of immune-related adverse events. So to conclude, immunotherapy is associated with various immune-related adverse events. It's important to promptly recognize what used to be under-recognized rheumatic immune-related adverse events, and the key to successful treatment is referral, prompt in use of DMARDs, avoiding the use of steroids whenever possible. And if so, delaying them by after the first 2 months, unless the disease is severe or the complication is severe or life-threatening. Little data exists on optimal choice of DMARDs, although more and more work is being done in that field. And patients, if there's one thing that I'd like you to retain from this, is that patients with pre-existing autoimmune diseases should be considered for immunotherapy, and flares of their underlying disease are common, but rarely severe and definitely manageable. Thank you very much.
Thank you so much for the fantastic comprehensive overview on a very important subject that I think we certainly all have to know about in the Department of Medicine. Beth, you're back on. Yes, thank you. I'll take some questions here. Dr. Sami, go ahead.
Yeah, congratulations. It's excellent. I'm very proud to do, but my question, you may have mentioned that for in the overall group of patients receiving ICI, what is the percentage of those that get grade 3 or more adverse events? That's the first question. And the second is that, is there any way of, I think you partially answered that question, but is there any way that you can screen patients ahead of therapy to know more or less who it will tend to have those adverse events?
So it's a good question. I don't know if everyone can hear it. Yeah.
Repeat it, yeah.
Yeah. So the question was on whether what was the relative proportion of grade 3 and higher or severe immune-related adverse events, and then if there was any way to screen for adverse events in general or more severe ones. Severe ones. Okay. Yeah. Well, when it comes to the risk of high-grade immune-related adverse events, it really depends on the organ system. Fortunately, they're rather infrequent, and it really will depend on the type of adverse event. Something like myocarditis is below 1%. Colitis could be, especially with combination therapy, something like colitis can occur in up to 10% of patients. It really depends on what we're talking about. Fortunately, in our case, severe rheumatic adverse events are infrequent, and even when the disease itself is severe, patients rarely die of their arthritis, right? And more severe diseases like scleroderma, vasculitis are rather rare. Now,
Screening?
The screening, well, patients with family histories of autoimmune diseases, patients who have pre-existing autoimmune disease are those who might have higher risks of flares or adverse events. I know that there's some data on IBD, and people with IBD are somewhat higher than baseline immunotherapy patients in their chance of getting colitis. I think I saw a figure of something like 19% develop colitis, and it could be more severe. But more work needs to be done in order to identify what are the risk factors.
Question for you about costs. So these ICI presumably are very expensive. And then you may be treating the side effects of these drugs with biologics, which are also very expensive. Can you give us an idea of like what we're looking at?
It's definitely costly, especially when it involves hospitalization for patients. Now, these are definitely expensive drugs, and with longer use, I think that like with what we use in rheumatology. I'm not sure if this is a phenomenon in oncology, but we have biosimilars, and that tends to limit the cost of these drugs. I think what we have to measure is what patients gain, and something like a metastatic cancer that used to be a quick death sentence in a matter of months is now transforming into more of a chronic disease that can be treated and managed and stabilized over years and years. And so I think that counterbalances the significant costs on the public healthcare system.
Dr. Roger?
Just from a sort of health services delivery perspective, I wonder if you could sort of comment on the role of the oncologists, hematologists delivering these drugs with ICI and adverse events versus rheumatologists. In other words, sort of what do they need to know, and what do they, what's the cut point at which they need to get you involved?
I've always welcomed referrals from oncology, even if the suspicion is low. There are some when it comes to the role of oncologists, I think it's to be vigilant and learn how to identify the more severe immune-related adverse events. I think that the oncologist will probably be able to identify those with mechanical versus inflammatory joint pain, and where there's uncertainty, refer. When it comes to rheumatology, I think there is a role in allowing patients to be in managing patients so that they can be maintained on immunotherapy for longer, because that tends to improve long-term survival. And so it's really a collaborative approach, and communication is key. And the intentions of treatment, or the importance of the treatment, patient with marginal benefits versus someone who absolutely must be maintained on immunotherapy. I think that's where the oncologist can help guide us in the intensity of our treatment.
Beth, any final comments? We're coming up on the hour.
Yeah, I was actually going to ask a very similar question. Nader, Dr. Toban, you've been getting a lot of referrals to GCSM. I tend to screen those referrals, and arthralgia versus arthritis. I think one of the things that we would all appreciate is that that patients have had a physical exam, that there's been some attempt to see if there's actually swelling of the joints, which would help us triage these patients. We learned very quickly in the COVID pandemic that rheumatology is one of the things that cannot be done by telemedicine easily. So when a patient's complaining of joint pain, it would help us if we had a preliminary joint exam prior to referral. But more a comment than a question. But I think we're butting up against 1 o'clock, and you promised me that we have to be finished by then. So
we have one last question from the room. Thank you.
Okay.
How many of these patients who were admitted to the hospital are then seen in your clinic afterwards? So for example, for further therapy. And the reason I ask is because the hospital institutional level, like requirement to submit to Vanessa's law to Health Canada for anything with grade 3 or over adverse drug reaction. So I know through the DCSM it makes it a bit more tricky because you don't really have access to, well, you can use your like laptop or
Yeah.
over it, but the MUHC sort of is supposed to capture anything over grade 3.
Yeah.
So if you're seeing them in your clinic, and kind of capturing them after their admission, and it would like not submitted before while they were admitted technically.
Yeah.
Go under, it would become the responsibility of whoever sees it first after.
Absolutely. But usually oncologists are aware of the complications, and they're informed of the outcomes, and
Because we're not receiving any sort of these reports from oncologists.
from oncologists.
Yeah, like the MUHC is not receiving these adverse
Okay.
drug reactions from oncologists, so I just wonder if you have any comments on
Yeah.
how we can capture these.
I'm not sure. I'm wondering if it's because these adverse events are not they're not necessarily unexpected in the sense that they are related to the drug doing its job in a way. But yeah, of course. And I think that that's something that could definitely be discussed, and better reporting is required.
Yeah, I think it's a conversation perhaps you guys can continue. Thank you so much. Really
Thank you.
wonderful, comprehensive review of this very important topic. So thank you so much and continue on with your great work.
Thank
you.